is my honor and pleasure today, our speaker for today, who is Elizabeth T. Peters. She's a medical doctor and a public health professional. She is also a project management professional and an award-winning lifestyle blogger. She's passionate about sexual and reproductive health rights and universal health coverage. Can we mute everyone, please? Everyone that's not speaking. Thank you. So please, if you're not speaking, remember the housekeeping rules. Kindly mute so that we can hear ourselves. Thank you. So she's passionate about sexual and reproductive health rights and universal health coverage. She has worked with a number of international organizations on these issues and is constantly aiming to improve health inequalities one community at a time. Currently, she leads a whole systems obesity strategy at the UK Local Council and provides care to ill children as part of a pediatric medical team, and is the editor-in-chief of her 7-year-old blog. The link is on the screen. You can join on to see what's going on there. So ladies and gentlemen, it's my honor to present or introduce our speaker for today, Dr. Elizabeth Peters. Dr. Elizabeth, welcome to the call, and over to you.
Hello, Ima. Thank you, everyone at mDoc for this opportunity. I'm very grateful to be here. Today, we're going to talk about rhesus incompatibility, and I expected my slides to come up. But whilst we're waiting for the slides to come up, I wanted to know how versed we are in this discussion, and if you have any pressing questions beforehand, so you can think about them as it's going on. Just put it in the chat as you go on, and I'll wait for my slides to come up. Or should we do the quiz?
Please, the pre-quiz is up. Dr. Elizabeth, some minutes for the pre-quiz actually, and then we on to the presentation since
That's
it's up
very
now.
fine. Thank you.
Yes, please, let's go ahead and take the next to attempt the pre-quiz, and then we'll just quickly go on to the presentation. Thank you. So the pre-quiz is up. I trust that we can see it. The first question is, what does rhesus factor stand for? Please speak your answers. Thank you. And the second is the rhesus factor important? The third question is, mother fetus rhesus blood type incompatibility occur if the mother is dash and if is dash. No pressure. Answers, and we would learn shortly if we're right or wrong and why so. And the fourth question is, which of the following are mother and fetus rhesus incompatibility problems? The fifth question is, can rhesus factor lead to the death of the fetus? And the sixth is, another name for rhesus disease is what? The seventh is, does rhesus incompatibility affect red blood cells? Next is, complications of rhesus factor incompatibility can occur during. All right, I see a lot of us have answered. Thank you. We'll just give a few more minutes to get our answers in. Thank you so much. We are doing well. Well done, and stay. Few minutes more, Timmy, and we can take this off and move on. Oh, thank you, Timmy. We can end the pre-quiz now. Thank you. All righty. Over to you, Dr. Peters. Tammy, we can end the pre-quiz. Thank you. So we'll be seeing our answers after the presentation. Thank you to everyone who gathered up the muscle to attempt the pre-quiz. Thank you so much. Over to you, Dr. Peters.
Thank you, Emma. Okay, yes. Thank you for participating in the quiz. So let's go right into it. This is a presentation on rhesus incompatibility, and we'll go further on. Let's go next slide, please. So let's go back to definitions, which is the first question on your quiz. What is it? It's a protein. It's on the cell of the red blood cells on the outer side. Basically, you can either be A positive or B negative, B positive, like that. So just positive, negative. That positive, negative is the rhesus factor. Most times, this is outside pregnancy. It doesn't make a difference to your life majority of the time. But in pregnancy, that's where we have the concern, and that's what we're going to talk about today in today's presentation. Next slide, please. So as I said before, in pregnancy is where we have a difference in the positive and negatives. So most people are positives. If you ask yourself, if I do a quick quiz now and ask how many people here are positive, how many people are negative, 95% will be positive and 5% will be negative. So it's that kind of variance. So it's not a very common presentation, but if it happens, it's something to be concerned about. So now, the few people that are negative is where we are concerned about. If a mother is negative, has A negative or B negative or O negative, then she has to consider her partner when she's getting pregnant. We'll see that in the next slide. Next slide, please. So rhesus disease is a condition where the antibodies in the pregnant woman's blood cells destroy her baby's blood cells. So it's when the negative and the positive come together, and that's when they realize that there's an issue, and the mom cells will destroy the baby cells. So the mother is negative and the baby is positive during pregnancy. Some of the baby's blood will go into the bloodstream, and that will make her to be sensitized against the blood cells. See it as a mother. The mother is negative, and then she is unable to. So that's her own body blood type. If she now gets if she gets exposed to positive, thank you, if you get exposed to positive blood, it would be a stranger to her. Next slide, I will explain this very well. Okay, thank you. So here's an image that will help us explain what's happening here. On the left side, we have the rhesus negative mom and the rhesus positive dad. They're in love, they're happy, they want to have their children. Fantastic, great. Now, mom, however, has a 50% chance of having a child that is positive or negative. In the event where the baby is positive, she now is having opposite type of rhesus to her child. So this is her first pregnancy, for example. Now, this is her first pregnancy. So now in this pregnancy, she will have some of the blood, this third image here, she will have some of the baby's blood will mix into her blood. That will sensitize her against the baby's blood. That baby's blood is a foreign blood to her blood. So her body will fight it. But in that first pregnancy, nothing will happen. She'll just be sensitized against it. So that's why she's now in the fourth image, she's now sensitized. You see, she has some plus of green around her. She now has the ability to fight against a positive blood again. It's the way you get your vaccines. Your vaccine gives you antibodies. Your body fights against. So whenever it sees that disease again, it will fight it again. That's the way your body fights. A negative mom fight against a positive baby. So following this pregnancy, if she doesn't do anything about it, if she's not aware that she has been exposed to positive blood and she's a negative mother, the next time her body will be ready to fight and it will fight the child. And that can really lead to the rhesus disease or hematological death of fetus. We'll see the whole topic right now. But the idea is that this is when her mother's mother's blood then automatically attacks the baby's blood. And then that can cause from mild to severe diseases. So that's the idea of sensitization. Next slide, please. Next slide, please. Thank you. So now let's go back. What can happen that before this one? Yes. What can happen that leads to desensitizing events?
Go stupid. Oh, go crazy. Yeah. Go stupid.
Please, we're taking out Samantha. Thank you so much. Sorry about that, Dr. Peters. Please go ahead. I'll just give a few seconds so that we can hear you. Yeah.
Okay. All right. Thank you. So these are events where it can possibly be sensitized. By sensitized, I mean being exposed to the blood of the opposite rhesus blood to yourself, the mother. So if a mother miscarries, if a mother has an termination of pregnancy or abortion, if she bleeds at any point during her pregnancy, antepartum hemorrhage, if they have any kind of testing that involves piercing through her to the baby, which sometimes we have to do sometimes, again, blood can mix. At delivery, and if it's an ectopic pregnancy, anytime that can lead to a mix of blood between the mother and the child and the baby is where you can have a sensitizing event. Next slide, please. So the symptoms of this look like, now it's actually a spectrum. Sometimes it can be very mild in that it'll just destroy the blood cells, but it will not have any actual effects. Sometimes it can be that mild if it's not too much of a sensitization, but it can be very deadly at the end of the spectrum. So the mother baby can look like jaundice, which is they have yellow skin, yellow nails, yellow eyes, or they may have low muscle tone. They'll be very floppy like this. They're very tired, lethargic, and it may have a lot of swelling or edema. That can happen even inside the pregnancy, but it'll also come up after birth. Next slide. So signs of this can also happen. This is what happens inside the whilst in utero, whilst still in the mother's womb. Baby can have signs of fetal anemia. Anemia is a low blood level, low blood volume. Yeah. So you can show this by polyhydria. This is when you have too much of the mom's fluids or water, as you can put it that, than the baby. So the baby there's now less blood inside the baby and more water outside the baby. That's polyhydramnios. It can be an enlarged fetal heart. They can see it on ultrasound scan. All this can be seen on ultrasound scan. There can be ascites and pericarditis. Ascites is like when there's fluid go up in the body. Like I remember studying in the abdomen, or that's where you have like a large amount of fluid in the body. Pericardial effusion is when there's a lot of fluid in the covering of the heart. So basically, there'll be fluid in the where it should not be fluid. That's the idea of how it will look like in fetal anemia. They can reduce fetal movements and of course abnormal CCG would reduce for it. So these are signs you can see whilst baby is still in pregnancy. If you see these signs, you should be questioning: have you seen your blood level, the blood group for the mother and the father, and so we can verify whether there's a potential of rhesus incompatibility going on in this baby. Next slide, please. Thank you. So how can we screen for rhesus? By screening, I mean, how can we prevent it? So this is how we can test. So we can test before it even happens at all. At the first time a mother comes in for her antenatal clinic, she should have her test for her ABO. ABO is blood group and rhesus. So when you do her blood, don't just say, are you A or B? You say, are you A positive or are you A negative? You have to clarify her type of rhesus, a positive, negative, that's why my rhesus, at the first visit. Because at that point, you can then ask her, okay, if she's negative, you say, okay, and what's your blood group of your partner? If she does not know, ask her to do a test. You have to make sure that they are sure of it. So we know that there's a risk or there's no risk of this issue of rhesus incompatibility. Of course, you ask her again, is this your first child? Is this your second child? Because if it's the first child, the issue is a matter of sensitization. If it's about the second child, then we know, okay, there's a higher chance of it leading to a rhesus disease. So again, after that first time pregnancy, check again at 28 weeks. Check her blood ABO and rhesus at 28 weeks. If she should bleed at any point after delivery, take her blood test. Maybe that might be the reason why she's bleeding. If she's bleeding during the pregnancy as well, check her blood test as well. And before giving any test, before you give any medication at all, check the blood levels to make sure take the blood ABO, the blood group and rhesus sign, positive, negative. And of course, the child, when her child is born as well, check the blood group of that child as well. That will help you to confirm whether or not this was a rhesus pregnancy or not. So for example, if a mother that's negative gives birth to a baby today, and you took her blood group at delivery, at her first visit at 28 weeks, and then at delivery you took the blood group of the child. If that child is positive, that means, and this is her first child, that means she has been sensitized. So that means you must be having your mind that you tell her that you have now been sensitized against positive blood as a rhesus negative mother. Thus, she needs to have ROGAM in her next. We'll talk about that in a few minutes now. In her next pregnancy, so she does not experience the whole rhesus negative. So you have to have this in your mind. Checking the blood of child, checking the blood of mother, so you can confirm whether or not sensitization has occurred in this pregnancy. Now, how do we test the blood itself? Of course, this is for the lab, our people in the lab, but just for you to know, the test we use is called indirect Coombs, and it mixes the mother's blood with anti-ROGAM. So it will therefore show you whether it's positive or negative by this blood test. That's how we do it very quickly in the lab with the right reagents. It can be done. So it can be done quite resource, even in the most resource constrained environments can be done. You don't need a very big machine or anything like that. It's a matter of reagents, and can test the blood for whether it's positive or negative. Next slide, please. Thank you. So now some complications. So during pregnancy, there could be mild anemia, hyperbilirubinemia, which is higher number of bilirubin in the blood level, and jaundice, even in the mother, because she may have, if this is the second time, if she's sensitized beforehand, she can start developing the signs of the fighting between her blood and the baby's blood in herself. There could be severe anemia and enlargement of the liver and spleen. Now, after birth is where we have our main concern. Severe hyperbilirubinemia, and which is like very severe, which like jaundice that has gotten to the level that's the bilirubin is what makes is bilirubin levels are high. So if that is very severe, it can lead to something called connectivity, which affects the brain and affects motility, and is quite devastating. So we have to conduct, these are the kind of reasons where we consider treating or preventing rhesus compatibility simply by doing the test at the beginning of the pregnancy. That way you know where the woman stands. Next slide, please. So how do we manage it in the event where it actually happens? So again, this is even beforehand, before it even happens. Beforehand, at 28 weeks, once you know the mother is negative, you give her anti-D prophylaxis. Anti-D is a rhesus is a D negative. So the idea is that it prevents you from creating too many antibodies.
I got it.
Antibodies against the baby's blood. So that's to give you that prophylaxis. In that injection, give her 28 weeks, will help her to not fight the baby's blood too much, not cause too much of sensitization happening between her and her baby. After delivery, if needed, you can give the anti-D prophylaxis as if their blood levels, if their percentage of sensitization is really high, you can consider giving another dose after delivery. We'll get to that next slide in a few slides from now. To get done now, what we want to do is we want to prevent anemia. You want to arrange donors before delivery for the baby. You want to ensure that there's blood available at the blood bank. And at birth, quickly clamp the cord so that you can prevent even more extravasation of blood on the other side, and send the cord blood for testing to again test the blood group and the positive or negative level. And again, you need to care facility in case it's quite a serious one. Have the position that plan that in case it's really bad, where will the child go? The child needs to go to the IC, neonatal care facility, where they can take care of people with the right machines, phototherapy. For example, for this kind of thing, for the jaundice now, you need phototherapy. So you can use a cloth to cover the baby's eyes and genitals and expose the baby to single light phototherapy, which will help to treat the jaundice as the effects of the rhesus. Also, if the baby's blood is very, very badly affected, they may need to have a transfusion of if less than 30%. So you can also get transfusion as well. That is if it's very severe. If not severe enough, you can do phototherapy, and it may still clear up the broken down blood. The reason why we're doing phototherapy, because your blood, the baby's blood will be getting broken down by the mom's antibody. That's the issue at hand. So there'll be more jaundice. As your blood cells break, the bilirubin comes out, jaundice comes out, and once there's bilirubin in the blood system, it goes to the brain, causes connectivity. So to prevent all that, we try to treat the jaundice with the blue light that comes from these phototherapy lights, and if we give it too much, transfuse the blood altogether. Okay, next slide. So I mentioned before anti-D prophylaxis. So this is like and this is an immunoglobulin. This is like administered to neutralize the positive blood that enters the mom's circulation. So sensitization is then reduced to 1.6 compared to 60. So if you don't give this injection, this immunoglobulin, the mother's blood will have a 16% level of sensitization. That means that she will have a very much higher chance or likelihood of fighting off possible if she ever comes in contact with again, aka in pregnancy again. If her second baby that comes out is positive and she doesn't take any injection, any prophylaxis, she'll have 16% level of sensitization, meaning she has a very high chance, in fact, almost 9%, so very high chance of her fighting off the baby and causing the disease. However, if you give this anti-D prophylaxis at 28 weeks, you'll be able to prevent her from sensitizing to that degree. You now come down to 1.6, which is very much lower. So it may cause some mild disease or mild jaundice, but it will not be, of course, as grand, as dangerous as it would have been if you gave her nothing at all. So when do you give this anti-D prophylaxis? So within 72 hours of delivery. So once she had delivered today, within the next 3 days, give her the anti-D prophylaxis. If baby's blood group is positive and she is negative, of course, that's the whole baseline of this whole discussion. If after every first trimester pregnancy loss, because again, this is like, so after any invasive procedures, if she bleeds in pregnancy, antenatal, and once you see that there are chances for blood to have mixed between the parents and mother, give her this injection, this immunoglobulin. That way you can prevent her from also having the chances of mixture between her blood and the baby's blood causing a disease. Also, in around the third trimester, there's something we call ECP, which is like extracephalic resuscitation. So let's say the baby is a breech baby. The baby's leg is down. Sometimes her gynecologist may obstetrician want to decide that she should turn the baby around, and that's the procedure we call ECP. So in that moving baby back to being head down, which is the normal route, they can be a mixing of blood. So that's also a reason why to give anti-D. Anything that may cause mixing of blood between baby and mother, you should think about, is this mother a negative mother, baby, positive baby, possibly positive, we don't know until they come out. Give them anti-D prophylaxis. Okay, next slide, please. So, of course, this is the dose and the route in case you find yourself being the one giving the injection. It's an intramuscular injection, most times given in the upper arm or in the thigh, wherever it's safe for you to give. And the dose is 300 micrograms of anti-D. And for it neutralizes 15 mils of fetal red blood cells or 30 mils of blood. So it can help to neutralize. It's not a large amount of blood, but so it's meant to be if for normal sensitization events, which is a small one, like not a large. If it's a large blood bleeding, you have to give higher doses, and that can be calculated based on how much blood is lost in that particular situation. But the standard dose for prophylaxis is this 300 micrograms. Next slide, please. So in conclusion, I really hope I've been very able to pass on this information. Rhesus negative pregnancies should be thoroughly investigated to rule out adverse effects of mother and on the fetus. So that way, you should think about it like, if I can prevent this disease, which is by testing accurately at when a pregnant woman comes to the clinic for the first time or at 28 weeks, to ensure that I know her blood group and that of her partner, I can then be able to rule out the possibility of there being a rhesus disease pregnancy here, and of course prevent us having to go through the long route of phototherapy and blood transfusion, when I can just prevent it by giving her the drug at the right time. Thank you for listening to the conversation.
Thank you so much, Dr. Peters, presentation. Thank you so much.